Good evening, everyone. Good evening, everyone. Welcome you all for the IPNA Endorsed Webmaster Series 2022. This is our third year, and this year we are covering all about pediatric tubular disease, and it is spanning from July 9th to August 17th, every Wednesday and Saturday. And the highlights is today we have the polling session. We are taking up the second polling session. And I'm very delightful and happy to introduce my own teacher, Dr. Georgi Abraham, who's going to be the moderator of the day. He is also a senior consultant at nephrologist at MGM Healthcare, Chennai. And he also works as a professor for IIT Madras. And he is a recipient of medal from American Kidney Foundation. And he is also the first recipient of Orophilus Award for his lifetime achievement in peritoneal dialysis. Over to Dr. Georgi Abraham to introduce the speakers for the day and to go ahead with the talk.
Thank you, Dr. Kalevani, for that high-end words about me, and also acknowledging that I am your teacher. So teachers always learn from students. So I have great pleasure today evening to introduce two speakers. First, I will do the first introduction, who is a professor from Boston, and he is a pediatric nephrologist, and Professor Friedhelm Hildebrand. Sorry about the mispronunciation. Affiliations are Harvard Medical School, Chief Division of Nephrology, Boston Children's Hospital. Areas of interest are major fields of study include CAT, which is congenital anomalies of the kidney and urinary tract, nephrotic syndrome, and retinal renal ciliopathies. He has received multiple awards and for his research, including the most important is the E. Mead Johnson Award for Pediatric Research from the Society for Pediatric Research, the highest research award given in pediatrics. So, Professor Hildebrand will speak about nephronophthisis, which many of us have very little knowledge. And good morning to you. And please be starting your slides so that we can listen to you.
Thank you very much, Dr. Kaidavari and Dr. Abraham. It's my greatest pleasure to present today. Let me quickly share my screen. One moment, please. I'll be speaking about nephronophthisis, as you know, a chronic kidney disease in children and young adults. And at the beginning, I will give a broader introduction into all cystic kidney diseases and then focus on nephronophthisis-related disorders. So in this next slide, 1 second, please. I have to grab the pointer. In this slide, I'm listing the cystic kidney diseases that occur before age 25. And in yellow, you see the disease groups such as polycystic kidney disease, nephronophthisis-related disorders that include senior-Loken syndrome and Joubert syndrome, Meckel-Gruber syndrome, Bardet-Biedl syndrome, and what's called oral facial digital syndrome. And there are a few shared features of these clinical syndromes. One is that all of them are caused by single gene disorders. And I'm listing the diagnosis and the diagnostic abbreviations on the very left column here. So there is autosomal dominant polycystic kidney disease, there is autosomal recessive polycystic kidney disease, nephronophthisis-related disorders, abbreviated as NPHP, medullary cystic kidney disease, which now is also called autosomal dominant tubular kidney disease, and then Meckel-Gruber syndrome, Bardet-Biedl syndrome with BBS abbreviation, again, oral facial digital syndrome. The genes that may cause these disorders are shown in the second column, such as the PKD1 and 2 gene, different NPHP genes for nephronophthisis, uromodulin gene for MCKD and mucin-1, Meckel-Gruber syndrome genes, and then the BBS genes that cause Bardet-Biedl syndrome. The related proteins and their names that you may recognize, many of are in the middle column. And finally, on the right, we are showing the associations, the extrarenal associations that can pertain to liver fibrosis, to central nervous system involvement with cerebellar vermis aplasia, CVA, for instance, intellectual disability, bone involvement, and other extrarenal manifestations that are characteristic for these nephronophthisis-related renal cystic disorders. Now, as I said, these diseases are caused by single gene disorders, and they are thereby so-called monogenic diseases, which are also called Mendelian disorders. And they're defined by the fact that in a given patient, the disease is caused by a mutation in one gene only for out of the 20,000 genes that we have in our genome. And these disease genes can be recessive, such as in autosomal recessive polycystic kidney disease. And in a recessive disease gene, as you know, both parental copies that we have for most genes need to be mutated for disease to occur. The parents will mostly be healthy heterozygous carriers, and usually the family history is negative because ancestors will also most likely be only heterozygous carriers. Whereas in a dominant disease gene, the disease travels through multiple generations because a mutation in one of the two copies that we have from our parents is sufficient to cause disease, such as in autosomal dominant polycystic kidney disease, where the disease travels through many generations. Now, the term monogenic disorder does not exclude that in different patients, different genes for each patient may cause a similar disease, and that's called genetic heterogeneity. For instance, a family can have polycystic kidney disease due to PKD1 mutations, or another family due to PKD2 mutations. And in fact, right now, there are over 100 recessive different genes that cause nephronophthisis-related renal ciliopathies. There's a 20 for plain nephronophthisis, some for senior loken syndrome, 20 for Bardet-Biedl syndrome, and so on. Now, if we want to understand what is so special about monogenic kidney diseases, then let's look at the flow of genetic information as it happens in every cell of the body. A gene is transcribed into a messenger RNA, which then is translated at the ribosome into a protein, and the proteins together determine our healthy or diseased phenotypes. Protein is derived from the Greek. It means proteo, I'm the most important one, because they're really important for bodily function. They're either enzymes or structural proteins, and together they perform the bodily functions. Now, in a monogenic disease, the mutation in this single gene out of the 20,000 represents the primary cause of disease or the etiology, and that's so special about them. So when we study pathogenesis, we do not have to speculate and do correlative studies on different proteins that may be increased or reduced in the cell. We know the primary defect is in not having the function of a single gene, such as the PKD1 gene. And from there on, we have a secure entry point to study the pathogenesis and derive all the cellular mechanisms. So the consequences of finding the causative mutation of a renal cystic disease gene are multiple. First of all, we can provide the patient and the family with an unequivocal molecular genetic diagnosis. Unfortunately, that does not necessarily lead to therapeutic consequences, but it often helps pre-transplant and even post-transplant to better manage the family and the patient's case. Now, gene identification also gives us novel insights into the pathogenesis, and great strides have been made there. It often allows us to draw genotype-phenotype correlations, which means that specific mutations in a gene lead to very specific disease phenotypes. For instance, strong mutations may cause early onset of nephronophthisis, mild mutations may cause late onset of nephronophthisis. And we hope by understanding disease mechanisms at some point we will be able to develop some specific therapy. But now let me jump to a brief overview, even broader in pediatric nephrology. What are the diseases that cause chronic kidney disease before age 25 in our patients, in children and young adults? And I'm listing here in 5 different colors, 5 different disease groups. Blue is congenital anomalies of the kidneys and urinary tract, or CACUT. Green is steroid-resistant nephrotic syndrome. Yellow is chronic glomerulonephritis, and I'm including atypical HUS. Cystic kidney diseases is what we speak about today: ARPKD, ADPKD, nephronophthisis, medullary cystic kidney disease, and then nephrolithiasis and nephrocalcinosis. And interestingly, here I'm showing the fractions in which chronic kidney disease that occurs before age 25 is caused by any one of these 5 different disease groups. And as you know, half of the children and young adults that have chronic kidney disease pretty much worldwide have some form or other of CACUT. 15% have steroid-resistant nephrotic syndrome, 14% have glomerulonephritis, if you include atypical HUS here, and 6% have the disease group that we speak about today, and 3% have nephrolithiasis and nephrocalcinosis. And what has happened in the last 15 years, many labs around the world and also ours have identified over 250 different monogenic causes of any of these diseases that cause chronic kidney disease before age 25. This has mostly happened by whole exome sequencing, and whenever labs discover these disease genes, they study the disease mechanisms. So there's right now for CACUT 45 different genes that can cause that. For steroid-resistant nephrotic syndrome, 68. For glomerulonephritis, 10. For cystic kidney diseases, there is 100, in fact. As I said, if you sum up nephronophthisis, 20 genes, Bardet-Biedl, 20 genes, and so on. For nephrolithiasis, there is 30 different genes. And now, in the last years, we and others have asked the question, in what fraction of these children, when you interrogate these 250 plus genes for mutations, can you actually find the causative mutation for this patient? And in CACUT, this stands currently about 1 in 5 of these children. In steroid-resistant nephrotic syndrome, there's a wide range from 12 to 45%, depending on the cohort, whether there's a lot of consanguinity, which portrays a risk of recessive disorders. In glomerulonephritis, it's at about 14%, excuse me. And in cystic kidney diseases, in 70% of all these individuals, if you perform molecular diagnostics in these 100 genes, you can actually find why this child or young adult has the disorder. And then in nephrolithiasis, nephrocalcinosis, that stands about 1 in 5 or 20%. And this fraction will keep rising as more genes are being identified. But now let's return to the disease group shown here in red, the topic of today, the renal cystic disorders, particularly nephronophthisis. As you know, renal cystic disorders have been termed as so-called ciliopathies because their function relates to primary cilia, which are little antenna-like structures that stick out from cell surfaces for most tissues and cell types, sometimes during development. And they're part of the protein and functional machinery of these primary cilia and the basal bodies from which they grow. These cilia transport receptor proteins up and down the cilium so that the cell can interrogate its environment and make decisions on cell proliferation and differentiation based on what it finds in its surrounding. Now, virtually all these gene products or proteins, which from the genes that if mutated cause renal cystic disease in us, in humans, or in mouse models, or in zebrafish models of disease, locate to these primary cilia or basal bodies. Now, as I've shown you, there are now over 100 different genes for whom that pertains. Their gene products actually interact, they bind to each other in these little protein submachineries that convey their function. And these protein submachineries localize to the primary cilia and basal bodies. Mutations in any of these genes cause PKD, nephronophthisis, Bardet-Biedl syndrome, senior Loken, Joubert, and Meckel's. And that's shown on the right, the renal cystic involvement, and then the extrarenal with retinal degeneration in Bardet-Biedl and senior Loken, with anosmia, inability to smell in Bardet-Biedl, liver fibrosis in Joubert, obesity, diabetes in Bardet-Biedl, and then some patients due to the ciliary dysfunction have situs inversus. However, how loss of the function for these many proteins and genes leads to kidney disease and any of the other organ involvement is still mostly unresolved. And when my lab discovered 35 of these genes, we tried to study their function and implicated multiple cellular signaling pathways as shown in the next slide. For instance, we implicated functions of Wnt signaling, which is a developmental program, calmodulin signaling, sonic hedgehog signaling, an important pediatric developmental program, cyclic AMP signaling, cell cycle regulation, and DNA damage response signaling. But now let me go back to the genotype-phenotype correlation. How does the clinical phenotype of any given patient relate to the potential gene involved? And that is shown here in a review. Now I'm using colors for a different purpose. Joubert syndrome in blue. And now in these bubbles, the color relates to the disease phenotype and lists the genes that give you that phenotype. For instance, Joubert, which can have kidney disease, nephronophthisis, but also brain involvement with cerebellar vermis, aplasia, and intellectual disability, can be caused by these genes that are shown in the blue bubble. Nephronophthisis or senior-loken syndrome or Meckel-Gruber syndrome can be caused by the genes shown in the red bubble, and you can already see that there's some overlap. Some of the genes shown here in the middle can actually cause Joubert syndrome or Meckel-Gruber syndrome. The genes that are shown in white actually include a liver fibrosis phenotype. Now, Bardet-Biedl syndrome is in orange on the right. Here are all the Bardet-Biedl syndrome genes, all the 20 of them, and some of them again overlap with senior-loken syndrome in this orange segment. Then we have skeletal renal related ciliopathies, such as Jeune syndrome, oral facial digital syndrome. They're shown in green, and again they overlap with other phenotypes. So, for instance, the genes shown in green in the upper left overlap with the blue. So some of these patients have cerebellar vermis, aplasia, and intellectual disability also. And on the right, some of the patients who have Jeune syndrome also have eye involvement, which is portrayed by the red color. Now, I'm using these same colors now when I go to the next slide, showing you the little protein submachineries, because the clinical phenotype shown here on the left relates to which protein submachinery is affected. So here's the cilium sticking out, and it's decorated in these colors. What I'm showing in green are actually proteins and genes of the so-called IFT complex, B and A, which is for intraflagellar transport. All of these proteins called IFTs actually are transported up and down these railroad tracks of the cilia to regulate the ciliary signaling and receptor function. And interestingly, whenever there's a mutation in one of these genes, then a skeletal phenotype is involved, as I've shown you in the next slide, in the previous slide. So there is this genotype-phenotype correlation that, depending on protein complex and protein submachinery, that determines the syndromic phenotype. Then we have in orange proteins that are called are part of the inversing complex. They have very similar phenotypes as the red ones here that are all at the transition zone of the cilium, which is at the base. Excuse me, and they cause nephronophthisis, shown here in red, senior-loken syndrome or Meckel syndrome, as opposed to the Bardet-Biedl syndrome genes, which are shown here in yellow, that cause Bardet-Biedl syndrome. Like phenotypes, but as I've mentioned, many of these phenotypes overlap for these different specific genes. I'm showing you pretty much the same message in another slide, where you can see how these protein submachineries around the cilium relate to phenotypes. In purple, Bardet-Biedl syndrome, all these proteins that cluster in this purple little piece of functional machinery cause Bardet-Biedl syndrome if defective. The ones in the IFTA and B complex involve skeletal phenotypes, and the ones at the transition zone are the nephronophthisis proper genes overlapping with senior-loken syndrome and Meckel. And still many other proteins are being identified through protein-protein interaction studies. I'm showing you an example here by Laurence Pelletier in Toronto at Sick Kids. And this will lead to the discovery of additional nephronophthisis-related ciliopathy genes. But now, back to nephronophthisis proper. As you know, it's an autosomal recessive cystic kidney disease, and it's one of the most frequent genetic causes of chronic kidney disease in the first 3 decades of life. In macroscopic analysis, you see the cysts that occur at the medullary border, and what is very distinct to polycystic kidney disease, that they're not all appearing all over, and that the kidneys retain their normal size or are a little decreased in size, whereas in PKD they're enlarged. On histology, you see tiny cysts, but also tubular basement membrane disruption and tubular interstitial infiltrations, interestingly. In senior Loken syndrome, you see retinal degeneration with 9 blindness in these children, and you see periportal liver fibrosis in Joubert syndrome, as well as cerebellar verpes hypoplasia or aplasia in Joubert syndrome. But interestingly, many of these genes that cause these diseases in children, if they have a stronger mutation, in other words, a truncating mutation rather than a missense mutation, they cause different phenotypes in the organs. They can cause enlarged cystic dysplastic kidneys in Meckel-Gruber syndrome, or they can cause lack of retinal tissue, in other words, a developmental phenotype in the eye rather than a degenerative one. Or they may cause biliary ductal place malformation in way of Caroli's disease rather than degenerative liver fibrosis. Now, there is this conundrum that in nephronophthisis related disorders that you see malformation or degeneration in some of these ciliopathies in these organs, whereas null mutations lead to early onset single organ developmental phenotypes of organ dysplasia and malformation, whereas milder mutations lead to late onset of kidney failure and multiple organ involvement in way of degeneration. I'm giving you one more example here. So here on the left is in these renal-related ciliopathies, kidney involvement, eye involvement, brain, cerebellum, liver, situs inversus, bone, and lung. And in severe disorders, you can have occipital encephalocele in Meckel-Gruber syndrome, olfactory lobe agenesis, biliary duct dysplasia with Caroli's, situs inversus, polydactyly in Bardet-Biedl, and so on. Whereas in some of the same genes, if you have milder mutations, the phenotype is completely different. And instead of coloboma, you have retinal degeneration. Instead of occipital encephalocele, you have intellectual disability. Instead of vermis aplasia in the cerebellum, you have vermis hypoplasia. Instead of lobe agenesis, you have anosmia, and so on. So this conundrum may have to do with the fact that missense mutations abrogate the interaction in these protein-protein interactions with only one other protein, and thereby lead to a relative dysfunction of this protein complex with only fewer organ involvement and milder symptoms and later onset, whereas truncating mutations may abrogate the interaction of multiple of these protein interactors, thereby to severe dysfunction of this protein complex, thereby to early onset of chronic kidney disease, and to a developmental phenotype where actually tissue is malformed, and as in Meckel-Gruber syndrome, leading to dysplasia and malformation in many organs. Now, in summary to this part, in nephronophthisis-related ciliopathies, by which I mean all of them except for polycystic kidney disease, there are over 100 genes that were identified. Each one is exceedingly rare. So each one causes disease in 1 to 10 out of 1,000 families with renal ciliopathies. The pathogenesis includes multiple signaling pathways from Wnt signaling to DNA damage response signaling. There is vast pleiotropy, which means different organs are involved by a single gene defect, including kidney, retina, liver, cerebellum, bone disease. And this is often in a gene-specific way, as I've shown you with these colored bubbles, where certain genes cause certain phenotypes. But then it's even more complicated that with different mutations in the same gene may cause different severity phenotypes. Now, there is by now equivalents of animal models for many of these human disease genes, which allows their study to be performed much more stringently. And then what is a characteristic of the nephronophthisis-related ciliopathies is that the proteins are part of little protein-protein interaction complexes, the so-called proteomes for the Bardet beetle proteome, which is called the BBS-ome, or for a proteome at the transition zone in case of nephronophthisis genes. And these proteomes appear to be at ciliary centrosomal subdomains, and they somehow correspond to organ-related involvement. Now, I would like to give you an example how whole exome sequencing and looking for mutations in a patient with chronic kidney disease and more than 2 cysts on renal ultrasound or persistent bilateral echogenic pattern on renal ultrasound, how interrogating these 100 genes may reveal the monogenic cause of this very otherwise difficult differential diagnosis. So here I'm showing, excuse me, on the upper left, a renal ultrasound from a 10-year-old boy, and you can see that there is 3 or more cysts in the left kidney, and the echogenicity pattern is much whiter or stronger than in the liver. And in fact, when we interrogated these 100 ciliopathy genes, we found a mutation in the nephronophthisis type 4 gene, or NPHP4. On the right, I'm not showing you an ultrasound, but histology. This patient had an SLC41A1 mutation, which causes echogenicity by hypomagnesemia. On the middle left, you see this kidney, left kidney, which was actually enlarged. And you may have already said this looks a little bit like a pepper salt pattern. So you would have guessed this could be autosomal recessive polycystic kidney disease, and you would have been right because this patient had a recessive mutations in the PKHD1 gene. On the right, there is often a mimic of cystic kidney diseases shown, where the kidney again is echogenic and has cyst-like appearance. And when we performed whole exome sequencing, we actually found that this is hyperoxaluria type 1 with a mutation in the AGXT gene. And these cases are often hidden in what is thought to be nephronophthisis-like disorders. So molecular genetic diagnostics is very, very important for an early diagnostic in hyperoxaluria. Now, on the lower 2 ultrasounds, these are from 2 brothers. They have renal cysts, large ones. But you may have said there's already some prominence in the echogenicity of the pyramid, so maybe there's nephrocalcinosis there, and you would have been right because the 2 brothers have distal renal tubular acidosis with the mutation in the AE1 gene, anion exchanger 1 gene, which causes the cyst-like appearance and bilateral persistent echogenicity in their kidneys. Now, we did a study in 79 individuals who before age 25 had on renal ultrasound either more than 2 cysts or had persistent bilateral echogenicity. And we've solved the molecular cause in 64% of them, and that is the blue segment on the left. The other ones in gray were unsolved, and the ones in red, we had a potential novel candidate gene. Now, if we take the blue from the left and make it 100% on the right, then interestingly, only, again, 64% of these mutations occurred in one of these 100 renal cystic disease genes. Some of the others were so-called phenocopies. It looked to the clinician like this could be nephronophthisis, but it was actually a different diagnosis. But since we ran whole exome sequencing, we identified the causative mutation. So in red, there were some renal tubulopathies. I've shown you the hypomagnesemia example. In green, some Alport syndrome was hidden or featuring as a phenocopy as potential nephronophthisis. There was some ARPKD, and there were some Cocoot patients with HNF1 beta mutations, for instance, and there were some very rare syndromes such as Apichet syndrome. So I think it's it's justified to say that these days and ages in any individual who has bilateral cysts before age 25 and bilateral persistent echogenic pattern on renal ultrasound, one should should offer to the family a renal diagnostic panel for these diseases, because in a high frequency of we did other studies of 70%, we can diagnose the molecular cause in these patients, which will have important consequences for pre-transplant management and clinical management, and also post-transplant management for many of these cases. So we made a website that we call precisionnephrology.org, where we feature a paper of ours where at Boston Children's Hospital we examined half of the children who received a renal transplant in the last 10 years, and we found it identified the molecular cause in 34% of them. And then in this paper we show what are the management consequences on the clinical side for these patients. And by gene, we give a list of what the potential consequences are. Excuse me. So you can click on these gene symbols that result from the molecular genetic diagnostics, and it leads you to this card or this one page that features, for instance, here for coenzyme Q10-6 monoxidase mutations, what the classic clinical features are and the potential consequences from identifying the molecular cause. This, as you know, is a steroid-resistant nephrotic syndrome gene. And as we've shown in others, when you diagnose this early enough, these patients may benefit from treatment with coenzyme Q10, which is an innocuous food supplement and has no side effects. And there's recently been a large study by Podonet, Franz Schäfer, an international study, that showed that onset of chronic kidney disease over 5 years can be reduced from 64% to 19% if these children are treated early. So this is one of the first results from identifying these monogenic disease causes with direct therapeutic consequences. Now, finally, I would like to give you a brief summary of when we identified new gene for nephronophthisis in a patient with a bone-related phenotype. Again, I'm showing you here the cartoon of the primary cilia and the interflagellar transport, where the proteins that cluster together are shown here in the blue box if they're part of the so-called IFT or interflagellar transport subcomplex B, and they're shown on the right in red if they're part of the complex A. So many of the genes from the A complex have been implicated in nephronophthisis-related ciliopathies such as TTC21B, and then also IFT80 had been implicated on the left. And they cause nephronophthisis-related ciliopathies that include a bone phenotype such as Jeune syndrome, Sensenbrenner syndrome, and Mainz-Saldino syndrome. And we performed whole exome sequencing in a collaboration with Miriam Schmitz and others in a large cohort of patients with nephronophthisis-like disorders. And in 12 families, we identified, first let me show you the clinical phenotype. Jeune syndrome is described as asphyxiating thoracic dystrophy, as you know, with this narrow thorax that postnatally leads to breathing difficulties. And so there's early onset postnatal respiratory distress. There's a high risk of death postnatally. And then survivors develop nephronophthisis-like kidney disease, liver fibrosis, and so on. The 5 genes that were known at the time are IFT80, dynein, C1H1, TTC21B, and WDR19. And when we examined this cohort of over 1,100 families from worldwide sources with a nephronophthisis-like disorder, we found mutations in 12 of these families, and they all turned out to have Jeune syndrome. And here I'm showing you the 48 exons of this gene, and the related protein structure. It has all these protein interaction motifs. The homozygous mutations are shown in yellow, and then the families who had compound heterozygous mutations are shown in white, overall 12 of them. And here's the phenotype that we saw in these children. There is the narrow thorax in asphyxiating thoracic dystrophy. There is the so-called trident acetabulum. Then these children have brachydactyly. They have short fingers. They can have polydactyly. If you do the count, this is actually 6 toes on both sides. They have cystic kidney disease with strong fibrosis. They have cerebellar vermis hypoplasia with this so-called molar tooth sign in the axial CT. And they have stunted growth, where this 10-year-old boy, for instance, would have a height of 100 centimeters. When we discovered this gene as causing this syndrome in these children, we also started to study its cellular function, and we confirmed that it's actually the protein localizes to primary cilia. And you can see a renal cell in cell culture, an NDCK cell, which we labeled with acetylated tubulin in red, so that just shows you the cilium. And then down below in green, we labeled it with an anti-IFT172 antibody, which is the gene, the protein of the gene in which we found to cause Jeune syndrome. And then on the upper right, we combine those two labelings, and you can see red plus green turns yellow. So in fact, IFT172 localizes to the cilium as expected, and the disease mechanism must, like with the other genes, have to do with dysfunction of the intraflagellar transport in these cilia. Down below, again, it was just labeled with IFT172 was labeled with green fluorescent protein. We also studied, in collaboration with William Schmitz, knockdown in zebrafish. If we knock down the IFT172 gene in zebrafish, whereas in the left column you see normal control, so this fish looks happy, and also in the renal region of the pronephros there is no cyst. Then the bony structures, which are shown in blue in the face, in the head of the fish, look normal, and they are shown from the side here. Whereas if you knock down the Jeune syndrome gene, the IFT172 gene with a morpholino oligonucleotide, the fish develop kidney cysts, shown here by the arrow. They have a very broad head, shown here in blue and also in the enfance view, where the children with Jeune syndrome also have specific facial features. And interestingly, very similar phenotypes were found upon knockdown on another intraflagellar transport component, the IFT80, which is also a Jeune syndrome gene, where there was a renal cyst, shown here with the red arrow. There was the broad head and face of the fish, and so thereby allowing us to study disease mechanisms in this animal model for Jeune syndrome. And I would like to stop here by thanking all the co-workers in my lab over the years, particularly the co-workers that were involved in the ciliopathy studies. I would like to thank many of you who are have been our clinical collaborators over the last 20 years and have contributed to all these insights. And we are very, very grateful to you. And I would like to thank for our support and for your attention. Thank you very much.
Thank you for that lucid and excellent presentation, Professor Hildebrand. And we will take the questions at the end of the session. So let me introduce you to the second speaker. The second speaker is Dr. Sushmita Banerjee. She is a consultant, Department of Pediatrics, CMRI, and Department of Pediatric Nephrology at ICH Kolkata. She is the president, West Bengal Academy of Pediatrics, section editor, Pediatric Nephrology Journal, counselor for India to IPNA 2013 to 2019, chairperson IPNG 24 to 25, peer-reviewed and published articles and chapters in several journals and books. Sushmita, it's a great pleasure to introduce you and to see you virtually after many years. So Sushmita will speak on polycystic kidney disease, and here is the podium for you. Sushmita.
Thank you. Thank you, Dr. Abraham. I'm just going to try and share my slides. Is that okay?
Yes.
Okay. Thank you, Dr. Abraham. Thank you, Dr. Kalaivani, Dr. Namalwar, and the whole team at Mehta Children's Hospital for inviting me to speak at this webinar. I'm going to present a short review of polycystic kidney diseases in children. And you've just had a really brilliant overview about the pathophysiology and genetics in renal cystic disorders from Dr. Hildebrand. I will be focusing mainly on the clinical aspects of polycystic kidney diseases. I will also mention some interventions that have been experimented on, particularly in adults, but also studies are starting in children, interventions that might retard the progression of these conditions both in children and adults. So this part of the talk will be very much in brief, and I will only pick up issues that apply to the clinical management of children with polycystic kidney disease. You have already heard about these conditions from Dr. Hildebrand, the renal ciliopathies, of which both the polycystic kidney diseases, the autosomal dominant PKD and the autosomal recessive PKD are a part. So you have also heard in detail about the primary cilium and the fact that these conditions, these ciliopathies arise because of abnormalities in proteins that are responsible for maintaining the function of this primary cilium. And ADPKD, it encodes this gene, these genes, that is PKD1 and PKD2, they encode the polycystin proteins, polycystin 1 and polycystin 2, whereas the ARPKD gene, which is PKDH1, encodes for fibrocystin, and altogether this forms the polycystin complex, which is necessary for preventing cyst formation in these conditions. So in these two conditions, the polycystic kidney diseases, we have cysts developing in both kidneys. And this is due to abnormalities, as we have mentioned, in the polycystin complex in the primary cilium, which gives rise to a host of intracellular metabolic defects and other defects, which give rise to a very high rate of cellular proliferation, expression of a secretory phenotype with excessive fluid accumulation, decreased apoptosis, etc. And all this gives rise to cysts, which are usually present quite early in childhood and then enlarge and develop both in number and in size throughout life. The formation of these cysts and their gradual increase progressively compresses the renal parenchyma and also the microvasculature of the kidney, which gives rise to kidney injury, inflammation, and ultimately fibrosis. So you get this picture of polycystic or fibrocystic disorders in the kidney and sometimes in the liver and abnormalities in other organs as well. And so this gives rise to the phenotype that we ultimately see in children. So let us first look at ARPKD, that is the autosomal recessive polycystic kidney disease. This is actually the much rarer condition. So approximately 1 in 20,000 live births are affected. However, because we are pediatricians and this group of children present early in life, I think most of us have seen more patients with ARPKD than we see patients with ADPKD. So the disorder in ARPKD is a fusiform dilatation of the collecting ducts. And these dilatations are present as small cysts, microcysts, in a radially arranged manner, as shown in this cartoon. When we look at sections of the kidney, you can also see these microcysts, which are again arranged in a radial cartwheel type of manner. They're called as spokes of a wheel, is the nomenclature used. And even in cut section of the kidney, you can see this orientation of the cysts. So the primary defect in the kidneys is the fusiform dilatation of collecting tubules. But 100% of the children who have ARPKD also have bile ductal plate malformations, which give rise to liver fibrosis. There may be associated intrahepatic biliary ectasia, which is also called Caroli syndrome, and some children also have extrahepatic bile duct dilatation. In about 20 to 30% of patients, the disease is very severe in the perinatal age group, and fetuses can be affected with severe oligohydramnios, which gives rise to the Potter sequence. So 20 to 30% patients will present after birth with pulmonary hyperplasia or other respiratory problems, and there is a high death rate within the neonatal period. Subsequent to birth, there is the finding of bilaterally enlarged kidneys, which are often palpable. And usually the ultrasound scan is the first examination that we perform. And as you have seen in Dr. Hildebrandt's slides, the characteristic is the very large hyperechogenic kidneys. We can't really see the cysts, but because the cysts are very small and they reflect the ultrasound rays, what we see is the salt and pepper appearance of the kidneys. As the children grow, sometimes small cysts can become obvious on ultrasound, and with further growth, they can even grow and develop so that they are difficult to differentiate from ADPKD cysts. So the diagnosis of ARPKD usually involves clinically an association of renal findings, liver findings, and family studies. So in the kidneys by ultrasound or occasionally by MRI when ultrasound is not very clear, we find enlarged echogenic kidneys with poor corticomedullary differentiation. In the liver, we find evidence of hepatic fibrosis, and previously, before genetics became commonly available, hepatic histopathology was a common route to diagnosis, which revealed the biliary ductal plate abnormalities. The family studies should support autosomal recessive inheritance, which meant that there was absence of renal cysts in the parents. Parental consanguinity was supportive of this condition, and a previously affected sibling also was supportive of the diagnosis of ARPKD. So a sibling that was affected, parents who were normal, and parental consanguinity was very much supportive of this autosomal recessive condition. Genetics I will talk about a little later. So this is actually, it's nice to be able to present this. This is the first ever publication of my life. This was in 1996. And I was then in the first year of my pediatric nephrology training in Great Ormond Street Hospital, UK, under really great mentors, as you can see. So what we did in this study was look at patients who had been born between 1950 and 1993. And the oldest patient actually was 42 years old. And here we saw that although most patients presented in the neonatal age group, with a few presenting later with hepatosplenomegaly, when patients survived the neonatal age, their outcome wasn't remarkably bad. So the renal survival was 86% at 1 year and 67% at 15 years. And the oldest patient at 42 years was still surviving on his native kidneys, although he had CKD. The commonest complication we detected was hypertension, with 60% patients requiring antihypertensive treatment by 15 years of age. And as the children grew older, we found that apart from hepatosplenomegaly, the liver complications became more prominent, with 23% having variceal bleeding, while death occurred in 4 patients due to bleeding from esophageal varices. Hypersplenism was seen in 20%. Now, at the time this study was done, genetic studies were not available. So all these children were diagnosed on the clinical characteristics I showed you in the last slide. That is the finding of the imaging findings, renal and liver histopathology sometimes, and by family studies. But then in 2002, the ARPKD gene, which is the polycystic kidney and hepatic disease gene 1, was discovered. And as you have seen, this gene codes for the protein fibrocystin, which is part of the polycystin complex of the primary cilium. The fibrocystin protein functions as a regulator of cell proliferation, apoptosis, and polarization, and abnormalities in this gene are responsible for this condition. You have heard Dr. Hildebrand also talking about the type of mutation. So truncating mutations are thought to represent a worse phenotype compared to missense mutations, but this really has not been proven in all the cohort studies that I have come across. There is also a lot of intrafamilial phenotypic variability, which is quite unexplained till now. About 15% of patients who have the clinical phenotype do not have PKHD1 mutations. And this is a relatively new gene which has been detected in some families who also present with a similar phenotype, but who have a relatively better outcome. So subsequent to this genetic discovery, the subsequent cohort studies are based on genetically proven ARPKD. So that you can see that this NIH study from I think 2010 and 2013, um, in this study, 78 patients fulfilled clinical criteria. However, only 73 were genetically proven to be ARPKD. Here, the presentation was perinatal in 42% and post-perinatal in 58%. Perinatal presentations were with oligohydramnios, respiratory symptoms, and a large number were ventilated, and 37% had pneumothoraces. Subsequent presentations were relatively milder, and again, the commonest was hypertension, and there were enlarged kidneys, UTIs, hypersplenism, liver complications, etc. On follow-up in these studies, it was seen that patients who presented perinatally had an earlier onset of end-stage renal disease compared to patients who presented later on in life. The other thing to note is that the kidneys were very large early on in the onset of the disease. But as time went on, and this is something we found in our cohort as well, that older children, in older children, the kidney did not seem to continue to grow. And with increased fibrosis, there was a stabilization in renal size. But with age again, the liver enlargement was more profound, splenomegaly was more marked, and the liver complications, variceal bleeding, requirement for portosystemic shunts, etc., these complications increased. And the screening of siblings of these index patients also yielded several patients who had been asymptomatic, but were found to have genetic abnormalities as well as ultrasound abnormalities. Now, how do we manage ARPKD? Unfortunately, till date, there is no real specific or curative treatment, and the management is largely supportive. So, perinatal planning in patients who have had antenatal detection is very important. So, these children need to be delivered in places where there is good NICU ventilation facilities. Early on in the disease, in the natural history, patients have been described to have hyponatremia, metabolic acidosis, urinary concentrating defects, and these need to be looked for and managed. Throughout life, there needs to be surveillance, good surveillance for hypertension. There are no studies that really look at what is the ideal blood pressure in a patient with ARPKD, but like in all other CKD patients, we would want a target which is less than 75th centile for age, sex, and height. Um, ABPM, the ambulatory blood pressure monitoring has been proven to be useful, and there are studies that show that nocturnal hypertension, absence of nocturnal dipping are common even in patients who have normal office blood pressure, and RAS inhibitors are usually selected as first line for therapy. There are many reports of unilateral or bilateral nephrectomies in these children, usually to make space to allow the diaphragm to allow the excursion of the diaphragm to allow ventilation, sometimes for severe hypertension and sometimes prior to renal transplantation to make space for the new organ. However, there are no real studies to show that these are of benefit in these conditions. So this is something that has to be decided on an individual case-to-case basis. The average, the onset of CKD is usually in childhood in this condition, and CKD management has to continue as per routine. Patients with age and with survival, as you have seen in the cohort studies, do develop portal hypertension, are prone to develop cholangitis, and these need to be looked for and managed. Immunizations for encapsulated bacteria are required in patients who have significant hypersplenism, and kidney and liver transplantation or kidney transplantation on its own or kidney and liver transplantation in patients who have severe liver disease are options in patients who have ESRD. And along with that, it is an autosomal recessive condition, so we need to screen the siblings to see if they are affected. Now, looking at transplantation in ARPKD, the outcome of renal transplantation is no different from renal transplantation in any other condition. However, mortality and morbidity post-renal transplantation is usually due to liver disease. And so there has to be a decision whether to go for just renal transplant or combined liver and kidney transplant. And the decision makers are the degree of portal hypertension, whether there is variceal bleeding, whether that variceal bleeding can be managed by standard therapy like banding, sclerotherapy, etc., whether there are recurrent episodes of cholangitis and sepsis. And based on these issues, individualized decision has to be taken whether to go for just kidney transplant or for combined kidney and liver transplant, both of which have their own potential risks and benefits. So the risks and benefits of these procedures have to be gone through to make the perfect decision for the individual patient. Coming now to ADPKD, it is much more common, as you can see. And because of this, it is thought that maybe we are missing many patients who are asymptomatic in childhood. So in ADPKD, the cysts form from tubular epithelium and then they get pinched off. So these are real rounded discrete cysts eventually, as you can see in the ultrasound scans and in the pathological specimens. ADPKD also has a wide spectrum of disease, both affecting the kidney and affecting extrarenal organs. As I said, cyst development usually starts early in life. often they are subclinical, we do not detect them, and macrocysts become more evident as the child grows. Cysts can form not only from the collecting tubules like in ARPKD, but from all nephron segments. And it is important to note that 2 to 3% of children with ADPKD have very early onset disease. So they can actually be mistaken for the ARPKD phenotype or may have unusually rapid progress in childhood. It is, of course, a very big cause of end-stage renal disease in adults. And we know that ADPKD is associated with a host of possible extrarenal manifestations like hepatic cysts, splenic cysts, pancreatic cysts, and most alarming is the intracranial aneurysms. So the genetics of ADPKD, that is the PKD1 and PKD2 genes, have been known for quite some time, I think the 1990s. And these code for polycystin 1 and 2, which form the component of the polycystin complex of the ciliary membrane. Again, in this condition, there's a huge amount of inter and intrafamilial variability. And it is thought that in patients with a genetic abnormality, maybe there is some sort of a second hit which decides how severe the disease is going to be. Severity of the disease has been linked to the type of mutation again, to sex, so males have more severe disease, to presence of hypertension, obesity, additional kidney injuries, and also the presence of additional genes. And I think the most marked of these is the tuberous sclerosis and polycystic kidney disease contiguous gene deletion complex, where you get very severe disease at a very young age. The difference between PKD1 and PKD2 mutations is that PKD2 mutations, this phenotype usually presents later with cystic disease, hypertension, and CKD, delayed by almost 20 years in comparison to people harboring the PKD1 mutation. And 7% of the ADPKD phenotype are mutation negative for PKD1 and 2, and some other genes have rarely been detected in such patients. So in children, how do we diagnose ADPKD? Because many of them may not be symptomatic. If you have a family history of ADPKD, that is the parents are affected, then the children have a 50%, because it's an autosomal dominant disorder, the children actually have a 50% risk of being affected. And in such children, even one cyst or enlarged echogenic kidneys are suggestive of this child having ADPKD. The corollary is that absence of cysts does not exclude the child harboring the mutation, and this may develop with age. And the big question is whether we should be screening asymptomatic patients or not, as I will discuss later. If you have a child with just cysts with no family history, then it is important to check parents or grandparents if the parents are young. Ultrasound is the gold standard, and occasionally, when things are a bit uncertain, MRI may be used. For over 15 years, the imaging diagnostic criteria are more than or equal to 3 renal cysts on ultrasound, or more than or equal to 10 cysts on MRI. But there are no real definite criteria as per number of cysts in children less than 15 years. In a patient with a single renal cyst without family history, and if the parents are normal, then it is suggested that we just follow up this child rather than doing genetics or many further tests. Now, genetic testing is available to many of us. And according to the recent international consensus on therapy in pediatric ADPKD patients, these are the conditions in which you would consider genetic tests in children. So one is young patients who are at risk. That means their parents or they have a strong family history of ADPKD, even if they are asymptomatic or have negative findings on ultrasound. And this requires a lot of thought and counseling, because making a diagnosis of ADPKD in children might impose a large psychological burden on these children, other than insurance issues and others. The second indication is at-risk patients who wish to be considered as live kidney transplant donors. This is not so much relevant in our childhood population. Uh, Third is patients with an unknown family history and enlarged kidneys with renal cysts, where we want to make a diagnosis of what this condition may be, or very early onset disease with rapid progression, even if there is a family history. And in this latter group of patients, it is important, as we have heard in the last talk, to do a panel of tests because there may be many conditions which present with a similar phenotype. Now, how do children present in with AD? How do ADPKD present? How does ADPKD present in children? Again, commonest complication seems to be hypertension, and hypertension is associated directly with the total kidney volume with left ventricular mass index. And this is something that needs to be picked up and screened for and treated. 20% of patients also have proteinuria, and 8% of patients have CKD in childhood. And this is from a meta-analysis from UK, looking at patients less than 21 years of age. Other complications may be abdominal pain, urinary tract infections, hematuria, and bleeding into the cysts. Nephrolithiasis, we've got a few patients, even though it says rare here, we seem to have a few patients with this. Liver cysts, mitral valve prolapse. There's a few case reports of intracranial aneurysms in children with ADPKD as well, but this is not common in childhood. So I think the ADPKD consensus statement of 2019, which is endorsed by IPNA, is something that we need to all look at. And I have just picked up a few of the points that are stated there to discuss here. So I have already said that in at-risk children, counseling prior to diagnostic tests is important because of the psychological and insurance issues, etc. The reason really is that early diagnosis does not really lead to major curative interventions or major interventions that can be used to retard progression at this stage. However, at-risk children should definitely be screened for hypertension and for proteinuria at least yearly and treated if these occur. Blood pressure targets should be less than 75th percentile. If cysts are detected, then cyst size and number, as well as the kidney volume, predict complications. But however, again, we do not have the studies that show us that management will prevent in any way the progression of this disease. Monitoring for progression for the utility of trials is usually done by MRI for cooperative children. However, MRI is a difficult thing to do in children who are not cooperative, who will need general anesthesia. And for these children, ultrasound is still the method of choice. Now, when we look at interventions for ADPKD or for any polycystic kidney disease, it is considered that children provide a therapeutic window when they have initially normal epithelia, which develops over years to the cystic phenotype. So there is this long period of time which may provide a therapeutic window for drug interventions. And these are some of the many drugs that are being trialed in these conditions, both in animal experiments and in adult trials. The only drug that is still now approved for use is tolvaptan. And tolvaptan is a V2, a vasopressin receptor antagonist, which when given to a group of patients with ADPKD with large total kidney volume, over a period of 3 years, it was seen that there was a reduction in the rate of increase in kidney volume, and there was a reduction in the rate of decline in GFR in the patients who were treated with the intervention. However, there were a lot of adverse effects as well, usually attributed to polyuria, and there were some hepatic side effects also. So the drug discontinuation rate was 23% in the intervention group. Subsequent post-hoc analysis of this study showed that the effect was similar across CKD stages 1 to 3, and that the effect was also present in adolescents and young adults between 18 to 24 years of age. And we now have tolvaptan trials which are being carried out in children with both ADPKD and ARPKD. So we wait to see what those studies show and whether they will prove useful in children with early disease. So at this point of time, what can we do to retard progression of this condition? So these are the predictors of rapid disease progression in adults. And we can extrapolate some of these to use them in the pediatric population. So the environmental factors we can look at. So we can try for lifestyle interventions, encourage physical activity and prevent obesity. And in fact, there is a pediatric study which shows that obesity is related to the increase in kidney volume in children with ADPKD. So salt restriction should be done as per the recommended dietary intake. Good amount of water intake is suggested, which suppresses vasopressin and reduces the cyclic AMP in the cells. And again, as with all patients with CKD, we would like to avoid NSAIDs and other nephrotoxic agents. The use of DDAVP is also suggested to be contraindicated because it might give rise to increase uh, in the cyclic AMP levels. And along with this, as I have mentioned, close surveillance of hypertension, proteinuria, and management of these needs to be carried out. And adolescent children need to be advised, adolescent girls, that exogenous estrogens can aggravate polycystic liver disease. So use of oral contraceptives in these children should be avoided. Till date, tolvaptan is not licensed for children, but off-label use can be used in individual patients where there is a risk of early progression based on the total kidney volume, rapid kidney growth, family history, etc. But the other drugs that are being trialed are still not licensed for use in children, and some of them include the mTOR inhibitors, somatostatin analogs, statins, and others. So what we do have is two drugs that are being trialed in children. One is tolvaptan, and another is a drug called TSV, which is a multi-kinase inhibitor, which is being tried in patients with ARPKD. Now, just to go through a couple of interesting patients. So both the patients I'm going to show you now are around 17 years old at this time. The first patient presented at 18 months with progressive abdominal distension. And as you can see, he had these huge kidneys, which were extremely echogenic with loss of corticomedullary differentiation. He also had Caroli's disease in the liver. The family studies showed that parents and siblings were normal. They did not have any cysts or any other extrarenal features, but there was a strong history of parental consanguinity. And this child was already on CKD at presentation with a creatinine of 0.88, and he was hypertensive. Now, at that time, we did not have easy access to genetic tests. We used to do a lot of HIDA scans. This is around 15 years ago. And the HIDA scan in this child showed a sort of a patchy uptake with an enlarged left lobe of the liver and a delayed excretion. So excretion occurs into the duodenum only after 3 hours. So all this was in favor of autosomal recessive polycystic kidney disease. An MRI scan showed uh, uh, so you can't see any cysts, but you can see the hyper intense signals on T2 imaging, and you can see this sort of a stippled radial appearance of hyperintensity as well. This child went into had CKD at presentation, went into ESRD at 12 years, was started on hemodialysis and received a renal transplant at 16 years of age. Despite this Caroli's disease, he did not really have any symptoms or imaging findings of portal hypertension. And pre-transplant, he had some genetic tests done. Um, in our country, funding is an issue, but we were able to find funding for this child. And what this targeted exome sequencing showed was that there was a likely pathogenic mutation which was homozygous affecting his PKHD1 gene. Probably the finding of an homozygous mutation that came from both his parents was because of the close consanguinity in this family. But what was interesting was that there were two other mutations also discovered, one of which was suggested to be damaging. So we do not know whether this had anything to do with the early presentation in this child, because this child otherwise had missense variations and not a truncating variation, which would have indicated a very severe early phenotype. The second patient is 12 years old. She was incidentally detected to have bilaterally hyperechoic kidneys, and it was different. Ultrasonographers actually reported the kidneys differently. So the first report said pelvic dilatation, and the child actually came about 6 months later with another ultrasound, which was done to see if the pelvic dilatation had increased. But at this time, the report suggested calyceal dilatation. And then a subsequent ultrasound said that there were parapelvic cysts. The liver gallbladders were normal, and clinically, there were no other extrarenal features. The creatinine was 0.6 at 12 years old, which was normal. Liver function tests were normal, and this child had hypertension. This was an adopted child, so we could not do any family studies for her. I don't unfortunately have access to these early ultrasounds, but she had a MRI early on after presentation. And as you can see from the MRI scan, the T2 weighted images do show presence of cysts, but then these cysts do not seem to be absolutely typical of what you would find either in ARPKD or in ADPKD. So this is what we would find in a typical ADPKD child with discrete cysts which are scattered in different parts of the parenchyma. So these cysts seem to be a little bit of a radial orientation, but again, large macrocysts. This is a follow-up ultrasound, which is current, which is at 17 years, which have shown that the kidneys have not really grown very much, but they remain hyperechoic, and the cysts are a little more discrete and prominent now. And this is what the genetics in this child shows. So this child was heterozygous for a PKD1 deletion. And therefore, since this is an autosomal dominantly inherited mutation, this was diagnosed as the likely pathogenic cause. So this child has been labeled as ADPKD. But again, what is interesting is that she also has a PKHD1 mutation. However, this is heterozygous, and we do not expect this to present with any disease manifestations because it is autosomal recessively inherited. But however, this led us to read up a little about heterozygous conditions in PKD. And if there is actually this study which looks at the hepatorenal findings in parents of patients with ARPKD. So these parents are obligate heterozygotes for ARPKD. And you actually find that these parents in this study also have multiple renal and liver abnormalities, liver cysts, renal cysts, nephrocalcinosis, etc. And then there are other studies which show that multiple PKD genes may be present in patients and give rise to uh, phenotypes that are different from the characteristic phenotypes we expect in ADPKD and ARPKD. So all this really, I think, makes you consider whether we can rely on clinical features alone. I think this has also been shown very clearly in our previous talk. So with ARPKD and ADPKD alone, when you compare the two, both have enlarged kidneys, hypertension, perinatal presentation, liver fibrosis, and end-stage renal disease in childhood. These are more common in ARPKD, but ADPKD can also present with perinatal presentation, liver fibrosis, etc. Asymmetric renal involvement, macroscopic cysts, extrarenal cysts, cerebral aneurysms are more common in ADPKD. Family history is in previous generations are more likely in ADPKD, whereas parental consanguinity is more common in ARPKD. So these are the classical characteristics, but there is often clinically a gray area where it is very difficult to decide which group of cystic diseases the patient falls under. And therefore, the access to genetic tests, whole exome sequencing or targeted exome sequencing is very useful. Particularly in patients where there is no previous family history or in patients who have atypical presentations. And genetics, I think, not only makes the diagnosis in the index patient and tells us about what may be the prognosis, but it also helps the parents decide about further pregnancies. And in the near future, we may have to decide on whether we will use interventions or not depending on the exact genetic mutation, which may be one of the criteria to determine whether to use interventions or not. So in the meantime, we need to screen for, manage issues like the oligohydramnios sequence, hypertension, proteinuria, CKD, liver complications. We need to encourage lifestyle modifications, as I have mentioned in previous slides. I have mentioned that in children, we have a therapeutic window which might be useful for intervention, and we await the results of the current drugs that are ongoing to decide whether these will be useful in children as well. There are several registries and biorepositories which are functioning on an international basis, which will hopefully provide further answers. And antenatal genetics and diagnosis is possible, but maybe in the future, we will be able to offer pre-implantation genetic diagnosis and management to patients with a diagnosis, to families with a diagnosis of these disorders. So just before I end, this is a childhood cystic kidney disease study. It is going to be a genetic study which is started in the Institute of Child Health in Kolkata. And everyone from India and neighboring countries are invited to participate. And the numbers, if you would like to participate, are mentioned below. So thank you. What the story behind this picture is that this is a huge jute plantation on the outskirts of Calcutta. And jute used to be a very thriving industry decades ago. But then with the advent of plastic, it was no longer needed for packing and for making bags, etc. So it just disappeared. And then now we have, again, there are a lot of ban on different types of plastics. So jute has come back in a big way. But then with jute plantations, you also have to have a huge amount of stagnant water. So it brings with it risks of mosquito-borne diseases like malaria and dengue. And so, with every good thing, every good intervention in the case of our polycystic kidney diseases, we have to balance the good with the bad and decide what is best for our patients. Thank you.
Yeah.
Unmute.
Yeah. Yes, yes. Thank you, Dr. Banerjee, for this excellent presentation. You were quite clear in your presentation. So do we have the questions for both the speakers? So if there are questions, let's move forward. Is there anything in the box, the chat box?
Yes, sir. We do have questions, sir. In
Yes.
Q&A, there are questions. You
Sure.
want?
No, you start question because I can't see the chat box.
It's in Q&A, sir. Okay, I'll read out the question, sir.
Q&A. Yeah, I'll go to Q&A.
Okay, the first question is, can there be multiple mutations in the same gene, CEP290, and leading to phenotypes to say Joubert, BBS, and Leber congenital amaurosis? Is this common in ciliopathies?
Dr. Hildebrand, Professor. Yeah.
Thank you for the question. So in CEP290, all the phenotypes that you list, they can occur, and they usually occur on an allelic basis. That means depending on which specific mutations a patient has. And the question with multiple mutations is, of course, each child will have two, one from dad, one from mom, and they can either be homozygous, that means mom and dad contributed the identical mutation, or they can be compound heterozygous. So each patient will have two. But it's been published at some point that there may be a third one, and that's been called oligogenicity. But I don't think that is a relevant situation because statistically it's very unlikely, and we actually published a paper where we thought you can have oligogenicity in children with nephronophthisis. However, years later, for the 4 cases that we published, we found explanatory mutations in an at the time unknown gene, so that the 3 alleles that we saw in these children were irrelevant, and it was actually explained by an unknown gene. So I would be very careful with genetic reports that list more than 2 alleles in a recessive disease gene. It is pretty much an inconclusive situation, I find, because the only way of showing what is really causative would be to make a mouse model that has all 3 mutations, and that's virtually impossible. That will take 10 years to do. So whenever you have the diagnostic situation that you have more than 2 mutations, in talking with the geneticists, you can together decide which ones are causative and maybe ignore the third one, or just tell the family and the patient that this is an inconclusive situation.
I am unable to get in the question answer thing. So, Kalevani, is there any more questions?
Questions. The next question is, there is a family of 4 children, and all 4 children are being affected with blindness, ataxia, and nephronophthisis. The first child has been landed with CKD at the age of 10 years. So how do we proceed with antenatal screening in this child?
Thank you. This is by Professor Prabha Sengutavan. I want to thank you so much for the year-long collaboration that we've had, probably 20 years or so. Great. Yeah, so the most important thing in this family with 4 would be to know the causative mutation, and I'm not sure whether this is known, because if it's known, then I would send the family to prenatal diagnostics that they do prenatal diagnostics specifically for this one mutation. If the mutation is not known, then it would be very important to find it maybe from autopsy tissue in that family from these unfortunately deceased children, because that is the much safer approach than having to do a whole exome in a situation of an antenatal diagnosis.
Kalevani, you have to unmute.
Thank you so much, sir. And the next question is tolvaptans approved for age of 18 years or 21 years in US?
Professor Hildebrand, the
And
question is to you, whether tolvaptan is approved as an aquaretic for management of polycystic kidney disease, United States.
actually, I have to say that I'm not sure, so I have to look that up. Sorry about that.
From what I looked up, it is over 18 years, tolvaptan.
Yes.
But the guidelines really suggest that guidelines in adults are quite detailed, and they suggest that you have to follow up patients for every 6 months for a period of at least 18 months. And there are a lot of details about the total kidney volume and the increase, the rate of increase of total kidney volume and the rate of decrease of GFR, which will make, which are, there is a lot of criteria which you have to use to determine whether your patient will get tolvaptan or not. So it's not that any child or any adult over the age of 18 can get it. It's just that patients who fulfill those criteria. Maybe Dr. Abraham, you would be able to
Yes, we use
enlighten
it.
further.
Yes, we use it in adults. I have patients as young as 25 years of age with autosomal dominant polycystic kidney disease. What I would do is I would get a GFR, a urine examination for proteinuria or for the other thing, and also a volume, measure the volume of the kidney. And then depending upon that, each kidney, and depending upon that, we start them on tolvaptan 15 milligram, 15 milligram a day. And in some oversized individuals, I may go up to 30 milligram. And I advise them to do a CT scan to look at the volume of the kidney every year.
So how long do we continue tolvaptans once it's initiated, sir?
Well, you have to continue until they go to end-stage renal failure, which we want to avoid, or they have some other complications, such as acute liver failure or something, which prevents the use of tolvaptan.
What about the polyuria and polydipsia, Dr. Abraham? Because it seems to me that is quite a prominent problem. And in children, it would be particularly difficult to treat children going to school, etc. How do you manage that end?
For adult patients, we tell them not to dehydrate themselves, but at the same time, we tell them also not to overhydrate themselves. So there is an element of that, polyuria, but for the sake of retarding the progression of chronic kidney disease, we tell them to continue it.
Okay.
I have a question to Professor Hildebrand. Genes, phenotype, clinical manifestations. India is a country with 1.41 billion people. And every year we have 30 million pregnancies and nearly the population of Canada now. So many of these children die. But the question is that, is there any role of, since these are all monogenetic abnormalities, is there any role of CRISPR in this?
Yeah, CRISPR-directed mutagenesis is probably a possibility for in vitro fertilization, and that's an evolving field.
Yes.
I think it, particularly for IVF, since CRISPR is so directed, there most likely will be a lot of development in that area.
Thank you. And the other question is that imaging is a difficult issue, especially in newborn child in our country. So when you do the imaging, we may get place A may say something, and place B may say something, place C may say something. Unless it is a pediatric nephrology oriented imaging center, we may come across difficulties in taking care of these patients and making an early diagnosis. Bardet-Biedl syndrome is very easy to diagnose because of the polydactyly retinitis pigmentosa and other features. But the other ones you are talking about, especially looking at the imaging of the kidney, it may be extremely difficult in our country. I am just trying to find out from our pediatric nephrologists.
Yeah, so Imaging, if it's difficult to be accessible for the patients, for the echogenic kidneys and
Yes.
cystic kidney diseases, there's always the option to run the panel of 100 cystic kidney disease gene, but there's also a problem with accessibility, whether it's supported, whether it's paid by the insurer, but that could circumvent the difficulties with access to ultrasound because it provides an etiologic diagnosis potentially.
Thank you.
So if I could make a
yes, please go ahead.
Can I make a comment?
Yes, yes, Dr.
So
Bal.
genetics, Dr. Hildebrand, in India are still quite expensive. The costs have come down recently, but it's usually out of the pocket expense for the parents. And very often we have to find some source of funding because they cannot afford to do the test themselves. This is quite often. So therefore we cannot really have a very widespread use of genetic testing unless it is under a research protocol where it is usually offered free of charge. Regarding imaging, Dr. Abraham, what we have, I think most of pediatricians, pediatric nephrologists have resorted to is that we know of 2 or 3 radiologists who are good in pediatrics. And we tend to utilize their services for the majority of patients so that we can then, call them and discuss and ask them to look for further details, etc. So I think most of us in pediatric nephrology, that is what we would do in every city. We would know who to send this child to for a good renal ultrasound.
I just have a question to Sushmita. Your presentation was very good, both of autosomal recessive and autosomal dominant. You stated that in both conditions, the kidneys can enlarge in size. My question is extrarenal manifestations, especially I'm little interested in knowing about diverticulosis and cysts in liver and cysts in adrenals, pancreas, or cysts in testis in these young children with autosomal dominant polycystic kidney disease.
So in children, we do not see very much of extrarenal manifestations. I can't remember. I mentioned the nephrocalcinosis in a couple of our patients, but then extrarenal cysts or intracranial aneurysms, I have not seen in my patients. And if you look at the guidelines, that the recent 2019 guidelines, the pediatric guidelines for ADPKD, they also suggest that don't go looking for these conditions unless the child is symptomatic in some way. So screening is not being advised because the prevalence of these complications are very low in the pediatric age group. Can I ask Dr. Hildebrand, the last patient I showed with the and then with the heterozygous mutation of the ARPKD gene, and then that study which showed the multiple abnormalities in heterozygous parents, what do you make of that? Because that really puzzled us in that child.
Yeah, that's again this difficult area of alleles that are borderline regarding their interpretation of deleteriousness. And I'm not too aware of the 2 papers that describe heterozygous symptoms in heterozygous parents, but I assume that there are cysts present in the liver and the kidney, but they're very few. So in other words,
Right.
they most likely are asymptomatic. So
Yes,
it's more
yes.
out of scientific interest, probably. In Alport syndrome, it's a little different because heterozygous women, depending on lionization with the alpha 4, with the collagen 4, alpha 3, and alpha 4 heterozygous mutations, can very late chronic renal failure. But this is a very quote unquote mild phenotype compared to the childhood onset. And I would assume that in ARPKD, the parental phenotypes are very, very mild because all of us pediatric nephrologists really are not aware of any significant cohorts with parental disease of these obligatory heterozygous parents.
Right.
Dr. Hildebrand, is it okay? We have two more questions. Is it okay to go ahead with the questions, or you want to?
Absolutely, yeah.
Yeah, and there is a question that can parents be a donor for a child with ARPKD? They need to do genetic testing for them before donation. I think this
Yeah,
question is for Dr. Shushmita as well, and Ken Hildebrand can add up to it.
yeah, in the
So
same,
please go
please go
ahead.
ahead
Yeah.
first.
No,
Why
no, no,
don't you?
go ahead.
Yeah, in the same vein, since they are most likely heterozygous healthy carriers, in theory they could be donors, but it has to be assessed in very thorough family counseling together with a geneticist, because there's also the risk that another child may have the same disease. So the family will be under duress if they donate one kidney and they want to have multiple other children, with a risk that there may be another child with a disease. But I'm interested to say what Dr. Banerjee will say.
I would agree if the parents are do not have any other conditions and are healthy, and they have completed the family and the other child has been tested negative, I don't see why there should be any contraindication.
Should parents undergo genetic testing in that case, ma'am?
To be on the safe side, yes. So, because sometimes something is false negative or false positive, and since this is a decision for a lifetime, I think I would do that first.
Okay.
And
That's
would you check the whole family when you do genetics on these patients? We usually start with the index patient, and then sometimes we are able to do family studies as well. But how do you approach them, Dr. Hildebrand? Do you do family studies from the word go? So you look at all the siblings and all the and both the parents?
Yeah, in the research situation, it's different. It depends on consenting them. And in the clinical situation, it falls all into the ethics rules that surround this question. One is that most regions in the world probably agree that before one performs molecular genetic diagnostics in a symptom-free child, non yeah, young person, um, that is a critical situation, because a young person may not be able to know what the consent means. So we don't invite DNA samples from symptom-free young people. And then, if in a dominant gene, if you want to study family members, you have to ask the permission from the patient that you're actually seeing, that that patient should speak to the family member whether he or she is willing to participate in the molecular genetic diagnostics, and then that family member at will can contact you as the doctor. So, in other words, that you cannot use the pedigree to access individuals without their prior consent. So, in dominant situations, I think it's kind of the rule that family members should talk to individuals who you want to include in the study first, and then they contact you as either the researcher or physician.
Okay.
there is one question for Shushmita, ma'am. In a patient with ARPKD with portal hypertension and hypersplenism, but without end-stage kidney disease, can we go ahead doing a sequential liver and kidney transplantation or combined transplantation? How do we go about it?
So I think this would be a scenario which would be fairly rare in pediatrics, because children tend to have more of the liver, of the kidney aspect of the condition, whereas when patients present at an older age, they have more of the uh, liver complications. So I think this is something that would have to be decided on per patient basis. I have certainly not come across this scenario in my experience. Would any of the other panelists like to answer? Would you do so if you have more liver involvement and less kidney involvement, would you do a liver transplant first?
As an adult nephrologist, yes, I would go ahead with a liver transplant because we had number of instances where adults had hepatitis C, which there was no treatment at all, and they had undergone liver transplant, and later on, they developed renal failure, and maybe the effect of hepatitis C, or it could be because of the calcineurin inhibitors and requiring kidney transplant. So the presence of a liver transplant has a beneficial effect because it produces more tolerance to the graft when you put a kidney.
Okay.
I think we are done with the question and answer session. Georgie sir, can you give the closing remark?
Yeah, I'm so happy that you asked this adult nephrologist to moderate this session. So it was a wonderful evening and also wonderful morning for Professor Hildebrand at Boston. And I'm extremely thankful to both the speakers for making it very simple. And we should have more of these sessions. And I want to thank Kalaivani, the pediatric nephrologist, and the IPNA for promoting these sort of educational activities so that other people can. There are a lot of nephrology trainees in this country who are looking for opportunities like this to listen to that and to also understand the basic mechanisms and how technology is taking it forward. Thank you and good morning, Dr. Hildebrand, and have a nice day for you. And Sushmita, I hope you will have a nice evening and
Thank you.
Enjoy yourself.
Thank you, Dr.
Thank you so
Abraham.
much again. Take care. Bye-bye.
Bye.
Thank you so much, sir.
Thank you.
We next have the interesting session, that is a polling session for the fellows and trainees. So we'll be taking up the polling session. Georgie sir, if you were interested in staying back for the polling session, it's fine. Just to
how long it will take?
It is just going to take 10 minutes, sir.
Okay, I'll stay.
Okay. So we'll just go to the instruction for the polling session. So I request all the participants who are going to take part in the polling session to enter their proper email IDs and contact numbers, because that is only the source of contact for us. And we are already done with one polling session, and we have 4 more leaving today's session. And totally we'll have 10 questions, and it is mandatory to answer all the 10 questions to proceed with submission. And the total duration is going to be 10 minutes, and we will have 3 star questions, and star questions are taken into consideration only in case of tie. And the cumulative score of all 6 polling sessions is going to be taken for the final marking. And I request all the participants to log in on time using a bigger screen for easy viewing of the questions. And only trainees are allowed to participate in the polling session. So we'll go ahead with the polling session now. So the total duration is going to be 10 minutes and for the 10 questions. We have 2 more minutes for the polling session. Last 1 minute. Last 10 seconds left. We'll close the polls now. Shushmita madam, you're still there? Shushmita ma'am? Georgie sir, can you unmute yourself?
Yes, I did.
Yes. Thank you so much, sir. Thank you so much for the moderation. I think Sushmita madam is still there. I think madam has not logged out, but madam is muted. Thank you so much, sir. It was really an enlightening session listening to all masters of the subject. Thank you so much for the wonderful moderation, sir.
Thank you. Thank you.
Thank you so much, sir. As usual, we have learned a lot from you. Shushmita madam is
Sorry,
here.
I just went out for 2 minutes. Sorry.
Okay. We are just done with the polls, polling
Okay.
session, ma'am.
Okay.
It was
Okay.
really
Thank you
nice
so much.
listening to you. And there is a mail from Dr. Hildebrand that he wanted to convey the message to Dr. Georgie and Dr. Shushmita that it was an excellent talk and it was a superb lecture. That is what he has passed on.
I think we learned a lot from his lecture, isn't it? Really learning from the person who has done all this work.
On all the
It's
studies.
really fascinating to hear.
It was a real insight. I have passed
Mm.
on the link to some of the DM students to listen to that because hardly ever
Right.
that topic about nephronophthisis is being
Yeah.
spoken. So at
Mm.
least they know that there is an entity which exists and
Mhm.
how to move around with that entity. I'm sure that many of them who listen to that would have some insight into this.
And there is a comment from Dr. Rajiv Sinha, sir, that one child has undergone liver transplant because of the cholangitis.
Yes. Oh, that's great.
Without renal failure, the child just had liver failure. So the child has undergone only liver transplant. And the child is, I think, 4-5 years back, the child has even undergone the renal transplant first. And now the child has undergone the liver transplant.
Great,
Okay.
great news. You have taken things forward. Yes, I still remember the first child I saw in 1992 came in the press of India. was a child, Kirti, from Bangalore, who came to us, and with liver disease and also kidney failure. So those days, we didn't have all these terms. We thought that it is a autosomal recessive polycystic kidney disease. And we put that child on peritoneal dialysis because there was no hemodialysis could not be done for the child. And they were with us at Tamil Nadu Hospital when I was there. Then they went to Bangalore. He was with Dr. Hegde, our pediatric, super pediatric nephrologist. Kishore Hegde.
Kishore Fatke, Dr. Kishore Fatke, right.
Kishore sent me the child in 1991, 92. I think it was in 92. So, so that's all what we could do at that time. There's nothing more we could do. And the PD fluid was not available, and the bags were not the smaller ones. Even now, today we don't have 1 liter bags in our country, despite speaking to the
you're right. Yes.
many times.
Yes.
So these are all adversities we face. But you people, the pediatric nephrologists, are taking the pediatric nephrology, to a higher level, so that we as adult nephrologists could learn. And because Kalaivani knows that I'm not a person who has ego. I would send if it is a pediatric nephrology where I have my issues, I send them to Kalaivani or to any other pediatric nephrologist. Or if they have difficulty in finding out, I usually send it to my colleagues in Toronto, to the hospital for sick children, which I used to do many years ago. Now I do not know who are the people at the hospital for sick children, the nephrology division. But I always used to do that, so that I learn and better care for the patient and also a better outcome.
You're absolutely right. And I think the internet has made the world so small. And so even when we don't have experts in genetic diseases and transplantation and other conditions, even when we don't have such people in the country, it's so easy nowadays to link up with people who have so much more experience because they started earlier than we did. It's been a great help to have that support.
Shushmita, madam, I just have one doubt from my end. Now we have a child who is actually has got features of nephronophthisis, but genetic test turned out to be negative. So I just really wonder if there is no genetic positivity. So how do we?
So what did you do? Did you do a whole exome sequence or
whole exome sequence? It is not just clinical.
So you saw that slide that Dr. Hildebrand presented, isn't it? That there's a certain percentage of each of these disorders that are picked up by the current mutation analysis. And I think all the time
how do we proceed and how do we counsel the parents? I just really wonder.
I've got similar patients. I've got a patient with frank hypophosphatemic rickets, absolutely frank, with low phosphate, the lower limbs affected, waddling gait, everything, but we cannot find a genetic diagnosis. So in those cases, I think we have to treat the phenotype, and maybe a couple of years later, we will find some new genes that or some other method that may be detected. The other thing is that whole exome sequencing might not detect everything, because if there are large deletions or there are several genetic abnormalities that whole exome sequencing cannot detect. So you might need different tests to look
generation sequencing.
No. For duplications and deletions, the copy number variations, you actually need different tests.
Okay.
So I would, in the first instance, I would talk to a geneticist that what other genetic tests can we do if you have a very strong phenotype of a certain disorder. And sometimes it's something different. So we always start with either targeted or whole exome sequencing. But if that doesn't show up and it is a very strong phenotype, then we have to look for things like chromosomal microarray and other conditions that look at copy number variations. And there must be many other types of tests that I don't know about.
Okay. Great having you here, ma'am. Thank you so much, ma'am. It was really a wonderful session.
Good to meet all of you. Good to meet you, Dr. Georgi, after several years.
So we'll meet in person in Calcutta.
See you in 2023.
Yes.
Okay.
Thank you so much, ma'am. Thank you,
Bye,
Georgi, sir.
Kalaivani. Bye.
Bye.
Bye then.
Bye, sir.